Hello and welcome to today's lesson. We are going to look at the abnormalities of the newborn and then the children. We'll be looking at preterm, small for date, and then large for date babies. Paedics I, we look at the normal baby. Paedics II, we are going to look at the abnormal babies. So the abnormalities that are pertain to the growing infant. We'll be looking at, for the objectives, we'll be looking at the preterm, the definition for preterm, the categories of preterm. Then you should be able to identify the characteristics of a preterm baby. We'll also be looking at the characteristics for large and then small for date babies. From there, we'll be looking at assessment. How do we assess these preterm babies? Then you should be able to give the means and then the domain by which we use in assessing these babies. Then the final aspect will describe the management of these preterm babies. So preterm babies are babies born before the 37 weeks of gestation or pregnancy. So if a child or an infant or fetus is born within the 37 weeks of gestation, we say that the baby is preterm. Let's look at the incidence. This occurs in every 7 births. So out of the 7, every 3 babies born are what? Preterm. So the incidence is what? 3 to 4% of all babies born before 37 weeks. They can also be classified as large for dates and then small for dates or preterm babies at large. And then some of them, although born before the 37 weeks, but the weight is more than 2.5. Normally, preterm babies, their weight is below 2.5 kg. Causes. Normally, there is no specific cause for preterm delivery, but we have predisposing factors. This includes poor socioeconomic status. When we look at the poor socioeconomic status, we are looking at poor diet, anemia, etc. in the mother. So we'll be looking at the causes pertaining to the mother and then that of the fetus. Second point of these predisposing factors, we have disease and then preeclampsia. Smoking and then alcoholism during pregnancy. Multiple pregnancy. When a mother is pregnant with twins, triplets, or quadruplets, the baby can be born preterm. Then fetal development abnormalities. When the fetus is in utero, some of them have some abnormalities as a result of disease condition of the mother can bring about these abnormalities, and then the baby is born preterm. Then short maternal stature. Normally, some of us, by nature, we are short, and therefore the uterus is also very small. And when the uterus is small, to accommodate this baby, there is no space for the baby to be planted in the uterus. And therefore, when they get to some age, they have to be born prematurely. Maternal age. Mothers below 18 years and then older women are prone to giving birth to these preterm babies. Then antepartum hemorrhage. When there is bleeding or some abnormalities for the mother during the pregnancy period, the baby can be born preterm. How do we assess these babies? Or how do we assess a mother for having premature delivery? We need to distinguish between preterm and then light for date maturity infants. We have to know their characteristics, and this will help us plan the care for the baby and also help the mother to understand the state the baby and then some idea of when they will be ready for discharge. So when a mother is pregnant, you will need to take good history, especially during the antenatal period. Find out if the mother has delivered a preterm baby before, and then we should be able to plan for the delivery of the baby and then the mother as well. Premature infants at 35 weeks may be active, able to control temperature well and feed from the breast beginning, whereas 28 weeks babies cannot do the same. So we need to find out exactly if the mother has delivered premature before. For the assessment, as I said early on, we need a careful history taking. When the mother is pregnant, we have to find out from the mother the last menstrual period. And this is best to guide us the length of gestation within weeks through contraceptives use up to the time the mother reported to the facility. Physical examination. When we do physical examination, it helps us to identify truly the weeks or the age of the pregnancy. Next on the assessment, we can also do ultrasound to indicate the gestation for us to be sure that yes, there is pregnancy in situ. The size of the uterus and then the measurement of the biparietal diameter of the fetal head. You know, some mothers, the diameter of the uterus and the pelvic bone doesn't accommodate the fetal head. So you need all these assessments to help you assess the woman if the woman is likely to deliver prematurely. After the birth of the fetus, we need to examine the body of the baby. There are several methods that we use to examine the fetus. These requirements, well-defined method, and a fair amount of practice. The criteria used are based on what? Neurological development and then a set of physical characteristics of the body which alters with what? Increasing gestational age. Let's look at the general characteristics of preterm babies. How would you identify a baby to be preterm? What are some of the things that you will see on the baby that will tell you that this baby is a preterm baby? In Paedics I, during your assessment of the newborn, we use the ABGA score and then the physical appearance. So these are the same parameters we are going to use in assessing the characteristics of the preterm baby. So we are starting from the head. The head circumference is bigger than the chest, which tends to be what? Relatively small and narrow. There are fine hair or laryngo on the baby's face, shoulders, and then trunk. It is more plentiful, especially if less than what? 30 weeks. So when the baby is born at 30 weeks, you see more of this laryngo on the face, shoulders, and then the trunk of the baby. The skin. How does the skin look like? Now the skin. How does the skin color look like? It's very smooth, more darker, pink than at times babies. Most of the time, with the term babies, the entire body is pink, and then the extremities are bluish. But with the preterm baby, they have smooth, more darker pink color than the term baby. In females, the labia minora have lanungo, protruding and then gaping of the minora. Labia majora do not cover the labia minora. In males, testes are undescended. There is low or absence of creases on the scrotum, especially in the 34 weeks of gestation preterm baby. Earlobes are flappy and lack of what? Cartilage. Because they lack cartilage in the earlobe, it tends to remain folded after the baby has laid or lain on one side of the body. So we urge nurses, as you put a preterm baby, make sure that the earlobe are opened. The skull is very soft and easily intended. So if you press on the fontanel, within this part, it remains what? Indented. The skull is very soft and easily indented around the fontanel before the 37 weeks of gestation. But this tends to become harder towards term as the baby continues to grow. There is no activity. The shorter the gestational age, the lesser muscular activity is shown in the baby. So we are saying that at the age that the pregnancy is due for delivery, the child may not show any activity in the muscles. Eyes. The eyes remain closed most of the time when they are giving birth to. There is weak cry. The baby lies very limp like a frog. The posture is less flexed. Muscle tone depends on gestational age. Legs and arms may be flappy, limp, mostly extended, or minimally flexed, arms only occasionally. So most of the time you see them, the legs are extended, and then they go like the posture of a frog. Prevention of preterm delivery. What are the measures that will be taken to prevent this kind of preterm delivery? One, we have to embark on good nutrition. During pregnancy, we need to take good nutritious diet to boost our immune system and then the circulatory system. The need to prevent infection. These are some of the factors that influence growth and development during the fetal development. Then good antenatal care. Antenatal clinic is very necessary in the period of what? Pregnancy. Complete bed rest if necessary. They need to ensure bed rest during pregnancy. And then they need to avoid or delay in the administration of corticosteroids, which will reduce the risk of what? Hyaline memory disease in the infant after birth. Because some people take in these drugs, it affects the respiratory system of the fetus. Antenatal care, we've talked about it already, good antenatal care. Some people may not attend antenatal care till the time of delivery. So we are saying that we should encourage mothers to attend antenatal care. Others too will never attend antenatal care till the pregnancy is 30 weeks. And at least you need to attend antenatal care 4 times before delivery. Regular visit to the hospital is also necessary. Avoidance of alcohol and then cigarette smoking. Education on the pregnancy and then the care of the fetus during this period. What are the principles of managing preterm baby? We have 5 main principles that we need to follow when it comes to management of preterm babies. 1. Establishment of respiration. Maintaining body temperature. Prevention of infection. Maintaining adequate nutrition. And then prevention of injury by minimal handling. If you could remember, during Paedics I, we said that the moment the baby is being born, you need to what? Establish good respiration. Therefore, you need to suction the baby, make sure the baby is breathing, and then they need to tap the baby to establish the first cry. And as the baby cries, the baby is able to inhale air into the body, and then the lungs, and then that will bring about the change of color in the skin. They need also to maintain good body temperature. The environment in the uterus is different from the external environment. And you were told that with the uterus, the temperature within the uterus is very warm. So the moment the baby comes out, you need to what? Maintain this uterine temperature. And therefore, they need to cover the baby with warm blankets to ensure good body temperature. What about prevention of infection? They need to ensure that all the instruments that we are using in conducting the delivery is sterile. And then also, good hand washing is very necessary to prevent the infection in the newborn. Adequate nutrition. The moment they are being born, we need to feed these babies so that the baby is able to attain maturity or grow up to term. We need to handle them carefully, embark on all nursing activity at a go to prevent what? Frequent handling of the baby. Apart from the delivery sets, we have to seek the need of what? Pediatrician. They have to be present before the delivery of the baby. They need to be present because if the baby comes out and there is need for medical care, quickly they attend to the baby. Delivery should also be at the hospital to avoid any hazard of what? Transfer of the baby. So if the baby is not delivered in a well facility, then transfer of the baby may die on the way. So we are saying that there is need for the baby to be delivered in a well facility that have all the gadgets to see to the maintenance of this baby. They need to avoid the use of what? Heavy sedative or narcotics to preterm babies' mothers. The moment we sedate them, it affects the baby respiration, and then the baby will be in distress. So they need to avoid these sedatives during delivery of preterm baby. We also have to give them episiotomy to aid the delivery. You know, the fetal scar is very soft and delicate. So if the lumen of the outlet of the uterus is so small, there may be what? Intracranial injury. That will also worsen the baby's condition. So they need to what? Give episiotomy to aid the delivery of the fetal head. Also, we have to make sure that all resuscitation equipment are ready, especially our suction machine, oxygen apparatus, and then incubator should be ready in case the baby is in difficulty, we can easily intubate the baby and then put the baby in the incubator. We need to observe strict aseptic technique to avoid infection. Resuscitation quickly is necessary to ensure lungs expansion. How do we care for the baby after the delivery? The baby must be handled very gently. Resuscitating the baby quickly by cleaning airway as soon as baby is born through mouth, throat, and then the nose. The baby must be handled very gently. Resuscitate the baby quickly by cleaning airway as soon as baby is born through the mouth first, nose, and then throat. You must receive the baby in a warm towel and place under correct adjusted radiant heater. Gently remove all dry fluid from the baby's body to prevent evaporation of heat. Administering oxygen to the baby as prescribed, and then you give your vitamin K to improve blood clotting. Daily injection of vitamin E is also necessary to improve on the eye of the baby. They need to what? Minimize disturbance and then handling of the baby. We have to place the baby in the incubator before we transport the baby to the ward. Subsequent care. What do we do? Now our baby is stable. What are some of the care that we have to give to them later? We have to continue to monitor the body temperature. Temperature is monitored rectally because we get accurate temperature reading when we use the rectal thermometer. Assessment and other procedures should be timed so that the infant is not disturbed often. We have to nurse the baby in the incubator and reducing what? About 10 to 14 days. The humidity should be around 55 to 60% if necessary. And then it's also necessary that the humidified oxygen is given with high concentration in order to avoid excessive drying of the respiratory tract. Prevention against cross-infection is necessary. Proper hand washing is necessary in caring for these infants. And then any nurse with upper respiratory tract infection is prevented from entering the room. Indoor dresses should be provided for every nurse attending to these preterm babies. All visitors should change into the indoor dressing before entry into the room of the baby. Use of what? Aseptic technique in all procedures that are being carried on the ward. We must also change all dirty linen immediately when they are wet and then clean the incubators daily with antiseptic solution and weekly changing of the baby incubator. Let's look at the observations that need to be carried on this baby. During the first 24 hours, careful observation and frequent recording of the baby's general state is necessary for them that are most very small. With this observation, we need to observe the general appearance of the baby and report on any finding. The color of the skin. How is the color? Is it cyanose, jaundice, pink? Is there any rashes or septic spots? We need to observe all these things on the baby, and then we report. How is the respiration? Is it shallow, deep, and then the rate? Is there any apneic attack? What is the heart rate, the pulse rate? And then we also look at the body temperature. Then we come to the cord. Is the cord dry, bleeding? Is there any discharge? Are the arteries and then the veins intact? So that if there's any transfusion, we can quickly rely on these arteries and veins in the cord. So we need to observe the cord for any bleeding, any discharge, and then if there's any offensive smell in the cord, then we intervene quickly. Meconium. As the baby passes meconium, what is the color of the meconium? We also look at the consistency and then the amount of the meconium. We also need to observe the urine. As the baby passes urine, what is the color of the urine? And then we report accordingly. Now let's come to the genitalia, the genital of the baby. If it's the male, you look for the testis. As the testis descended, how does the scrotum look like? If it's a female, we look at the labia minora and then the labia majora. Do they cover each other? Is it gaping? Is it overlapping? We also need to assess all these features in the genital region of the baby. Then we come to the scar. How does the scar look like? Is it soft, hard? The sutures, are they all present? The fontanelles, is it bulging, sunken? And this tells us if it's bulging, then there is what? Accumulation of fluid in the scar. If it's sunken, then dehydration is setting in, and then quickly we intervene. How does the eyes look like? Is there any discharge? Color of the conjunctiva, how does it look like? Is there any yellowish coloration on the eye? All these things we have to look and then we report on it. Good. Now, let's look at how we clean the baby for the first day. We are saying that these babies are not dirty dough, and we need to provide or maintain the warmth of the baby. So cleaning is done gently within the incubator. We only remove what? Excess venous caseosa on the body. And then light cleaning with what? Sterile moistened swab for soiled perineum where necessary. Especially if the baby has passed meconium, we need to clean the vulva carefully and then the genital area so that the baby will maintain the warmth. And then the cleaning is done alternate days. Full bathing is done when the baby is ready to go home. There is no need bathing the baby. Just top and tail is enough for the baby in the incubator. Weighing. Weighing is done to know the change in the body weight, especially to guide the regulation of fluid intake. Weighing should be done twice in a week. The accumulation of edema from renal and cardiac failure may cause an excessive weight gain, and there is relatively big drop in weight when it's diminished. So these changes must be allowed for some time. So we need to assess, is the child having any renal condition, any cardiac problem? Because when the child is having these conditions, it brings about increase in weight. And then as time goes on and baby is being nursed for some time, the weight drops. So we need to assess for this condition before we take down the weight of the baby. Feeding. That is the nutritional aspects of the principle in the management of the preterm baby. Early feeding has greatly improved the prognosis of a preterm baby. So when we feed the baby immediately, the moment they come, it improves their what? Their lifespan and then the prognosis. The risk of regurgitation and inhalation of milk in the first day or two is greatly overweighed by the benefit. So we are saying that although some of them may regurgitate and then aspirate, the need to feed them is of benefit than ensuring the baby going into hypoglycemia. So when we feed them, we prevent hypoglycemia, dehydration, and then undernutrition. So it's very important for us to assess and then start feeding immediately the baby is born. Most very small immature baby need their feed and calories requirements intravenously. So some of them, they cannot go straight to the breast depending on their gestational age, but we need to pass an NG tube, or we can pass a line and then we give them IV fluids. Where the baby can tolerate the first feed is given 2 to 3 hours after birth, and then subsequent feed frequently will depend on the maturity and then the method to use. So as I'm saying, some of them can go straight to the breast depending on the maturity. So this feed should be given too early or early in smaller infants or larger babies 3 early. The mother's colostrum provides some form of protection, and I believe you remember colostrum. This is the first breast milk that comes out, and it contains all the nutrients and then protection against infection. So we encourage them to express the breast milk, and then we feed the babies with the colostrum. So let's look at the method of feeding. The method for giving feeds depends on the size, maturity, and then the strength of the baby. Babies more than 35 weeks of gestation are able to take their feed by bottle or directly from the breast. Less mature babies may also manage to take part of the feed, but through nasogastric feeding. And that is the best method for small babies. You pass the NG tube, you express the breast milk, and then you feed the baby through the NG tube. It is important to use NG tube than allow the preterm baby to exhaust him or herself with prolonged period of ineffective suckling. Because at that stage, the reflexes are not well developed, and then they may not be able to suck well directly from the breast. So you pass NG tube, you express the breast milk, and then you feed through the NG tube. With good supervision, the parents can also be taught how to feed through the NG tube. So when you pass the NG tube, you teach the mother how to feed the baby through the NG tube. We can also use the nasovaginal feeding, where we pass through the stomach into the jejunum, and then we reduce the risk of aspiration. Because most of them do aspirate the feed, and then they die of aspiration pneumonia. So we need to avoid the aspiration, and then we use the nasovaginal method of feeding. Let's look at the requirements for feed. The amount of food that you are supposed to feed them per day, depending on their size and then the maturity. The amount of feed necessary depends on the baby's size, maturity, and age. The requirement of the feed varies from the average volume of milk needed by babies under 2 kg per weight. So I've given an example as follows. So day 1, when the baby comes out and the weight is determined, we feed 60 ml per body kg. So if the baby is weighing 2 kg, it means we are feeding 120 ml of milk per day. So that's the weight of the baby determines the amount of feed you are supposed to give per day. Day 2 is 90 kg. So we know the weight of our baby already is 2 kg. So day 1 we give 120. So day 2 we are going to give 180 per day. So it keeps on increasing. Day 3 we are giving 110 ml. And then day 4 we are giving 150 per body kg. So you have to bear in mind, know the weight of the baby and then the amount of feed you are supposed to give per day. There is little weight gain, of which occurs in the first week, after which the child is expected to gain 12 grams per body weight. In the absence of edema, indicates an adequate calorie intake, and the volume of feeds should be adjusted within the limits of what the baby tolerance. So when the baby is not having edema, it means that the baby is gaining the right weight, and we should adjust the feed so that it suits the baby's rate of taking in the food, and then we maintain the growth rate. There is also need for us to give food supplements. The preterm infants below 32 weeks of gestation has an increased liability to develop rickets after about 3 months of age, and this is due to what? Phosphate intake. Breastfed babies should receive a phosphate supplement of 30 to 40 milligrams per day, and then 800 IU per day of vitamin D to ensure good bone mineralization. So we need to give them these supplements so that the bone and every aspect of the baby, especially when it comes to teeth eruption, the bone needs the calcium, the phosphate, and then the fluorine. So we need to fortify the food or the feed of the baby with these minerals. And you know, in utero, every gestational age and then the developmental stage that takes place. So within 32 weeks, the baby is being given birth to lack all these minerals. Most of them comes after the 35th week. So if a baby is born before this week, then the baby is going to lack these nutrients from the mother, because they need to acquire all these nutrients before they are being given birth to. But because they are being born early, then they lack these nutrients. So when they come out, we need to fortify their food with these supplements. All growing preterm infants should also receive vitamin A and then vitamin C. Iron phosphate is also necessary per body weight. The preterm milk lack phosphate. Sometimes they are fortified with what? Phosphate. As I said early on, you need to fortify their food with these nutrients. The vitamin C, the mother has to take it, and then the baby gets it. But because the mother is not able to give this baby this vitamin A and then C before giving birth, the moment they come out, we need to provide them with these minerals. What are the roles that the parents need to take in the care of preterm babies? First, we have to give them psychological care. We need to encourage them. We need to involve them in the care of the baby. Some of them run away and leave the babies for the nurses. So your first role as a nurse that you have to carry out is that you need to provide psychological care for the mothers. You need to encourage them, involve them in the care of the baby so that they become familiar with the care of the baby. We need to give them health talk. Teach them how to care for the baby. We need to tell them how they will help the prevent infection in the baby. We also have to help how to establish bonding. Very, very necessary. The bonding alone will provide warmth for the baby. We also have to teach them how to feed the baby. And then good health promotion. Because if we don't teach the mothers, they cannot take care of their preterm babies. So we have to give them the psychological care, encourage them, involve them in the care, and then teach them as to how they will manage this preterm baby without any problem, how to prevent infection, establish bonding, how to feed these babies for them to maintain the normal growth rate, and then health promotion in the baby. Now, let's look at some common disorders that we can see in these preterm babies. They have a whole lot of problems, very, very serious problems. If you are not able to manage these babies well, they can die within a minute. 1, respiratory problems. They have period of apnea, periodic respiration, with repeated short time spell of very shallow breathing or complete cessation lasting 3 to 10 seconds. So you see the baby lying down, and then if you observe the baby critically, you see that the baby is not breathing. And then you see the mothers crying, calling you, my baby is dead, my baby is dead. You go and then you observe for some time, then you see the baby will start breathing again. So they have this periodic respiration. With time, they cease breathing for some time, and then they start breathing again. So you need to reassure the mothers. You need to reassure them, encourage them, just to be critical, observing in their observation, and then if anything, they call on you. So that is the periodic apneic attack. True apneic attack are different from what? Potentially more serious. Breathing stops suddenly. Apnea usually lasts for 20 seconds and may accompany by what? Cyanosis and bradycardia. So if the child is not breathing, definitely there is no oxygen in the body. And then you see the baby becoming blue. And then bradycardia, which means what? Low pulse rate. So you need to observe the baby critically. If the need for resuscitation, you resuscitate the baby. And then if possible, you also give oxygen. So you need to observe the baby critically. What are the predisposing causes of this apneic attack? We are saying that number 1 is hypoglycemia, where there's no sugar or glucose in the blood. That is why we are saying that nutrition is one of the major principles in managing preterm babies. So the moment they are being born, within 2 to 3 hours, you need to feed these preterm babies. Other than that, hypoglycemia alone can bring about this apneic attack. Also, when they have cerebral bleeding that is entering into the brain cavity. And when this happens, it means that a vein or an artery has been ruptured in the brain. And you know we have the respiratory center in the brain. So when they press on this respiratory center, it prevents them from breathing. And then the baby may suffer this apneic attack. Also, when they have electrolyte imbalance, the baby can also go into apneic attack. And you know our sodium and our potassium, they are the main elements, the intracellular and then the extracellular minerals. When the baby is lacking these minerals, it brings about difficulty in breathing, and then the baby may cease breathing for some time. Presence of sepsis, infections. When the baby is having any infection, especially with the mother, if the mother is having any infection and then they didn't detect it early, and then the baby passed through the birth canal, the baby is likely to have this infection. And when it's not detected early after birth, this sepsis can go into circulation, and then the baby may have apneic attack. How best do we manage this baby then? We need to treat any underlying cause. So quickly do your assessment, thorough assessment of the baby, and then you treat any underlying cause. Give oxygen as prescribed. Then they need to stimulate the baby to breathe. That is why we need to establish the first cry the moment the baby is born. So that as the baby cries, the baby is able to breathe, and then it will solve this apneic attack. Then they need also to inform the physician or the pediatrician if there is still this apneic attack present. We need to also handle them with care. Minimal handling of the baby will also prevent the baby from this apneic attack, because already they are small, they are delicate, and then their respiratory centers are not functioning enough. So if all the time we turn them here and there, they are using more energy to breathe, which will help bring about this apneic attack. They also have this respiratory distress syndrome, difficulty with breathing soon after birth, increased respiration rates, granting respiration. And then the main cause of this respiratory syndrome is meconium aspiration or infection. Meconium aspiration occurs as the baby passes meconium in utero. And you know we have amniotic fluid in utero, which cushions the baby. But if the baby has passed this meconium in utero, it means that the amniotic fluid is mixed with the meconium. And then this baby takes in this amniotic fluid, and then the baby aspirates with it. And it will bring about this respiratory distress syndrome. Now we are moving on to the gastrointestinal tract problems. Do they have GIT problems? Yes, they do have, because they take in food. So there is problem also there. The baby may regurgitate feed. And when I say regurgitate, some of them after feeding, they bring out the feed. And as they bring out the feed, they may aspirate with the feed. There's also vomitors. The baby may vomit and then may pass through the nose. And we normally see this thing even in full-term babies. Some of them, when they are feeding, they overfeed and then they vomit. And as they vomit, you see some of the feeds passing through their nose. How best do we manage these GIT problems? When this kind of regurgitation and vomit, and then as it passes through the nose, you just turn the child to one side, or you suction the baby. You may also have the abdomen distended as a result of what? Gaseous dilation of the GIT, especially in the second week. Some of us, if you are not able to position the baby well to the breast, that the baby is well attached to the breast, instead of the baby taking in the breast milk, it's only gaseous exchange that is going into the baby. And this brings about what? Distension of the abdomen. And as this occurs, this distension occurs, it presses on the diaphragm, and then the baby will not be able to breathe well. So with this distension of abdomen, the best treatment that you can give to the baby is what? Modification of feed. We said that we don't schedule baby feed, but we feed them on demand. But when such distension of abdomen occurs, we need to schedule the feed for the baby. And then we also make sure that the baby is well attached to the breast. It can also be a manifestation of more serious disorder, such as what? Septicemia. Hard feces in the lower column or the rectum may also be a problem. Some of them have constipation, all because the mother is not taking in good nutritious diets. So you see the baby having this constipation. And when they have constipation, it brings about what? Distension of the abdomen. So when it's happening this way too, we don't have anything than to do gastric lavage or gastric washout. Jaundice is also part of the GIT system. They may also have jaundice due to what? Immature liver function, because the liver should be able to conjugate the bilirubin, and then they will be excreted through the feces and then the urine. But because they are premature, the liver is also not matured enough, and then the bilirubin is being accumulated in the system, and then the baby appearance or the skin color will change to yellow. If this bilirubin is not able to be cleared out of the system, they cross the blood-brain barrier. They go into the brain, and this results in what? Kernicterus. The consequence of this kernicterus is that there is what? Nerve damage. And then there will be deafness, learning difficulty, and then cerebral palsy in the child. So you see, the child will grow. If the child is able to grow well, at the end of the day, the child may be having learning difficulty, or there may be what? Cerebral palsy. How best do we manage this jaundice in preterm babies? We do phototherapy. If the jaundice is so severe and then kernicterus is setting in, we do exchange transfusion, where the blood of the baby is changed totally by transfusing the baby with another blood. So you remove all the blood from the baby and then you replace it with different blood. Edema. Some of them, you see that they have this shiny, full appearance of the skin. And this indicates what? Water retention. True edema with pitting on pressure due to what? Probability to the capillaries permeability. And it's very common in the first week. So some of them, you press on the skin and then you see the pitting edema with what? Space or indentation in the skin. And it normally affects the face and then the feet or the external genitalia. So when you take the baby you need to assess the baby. You know, when we were in Paedics I, we assessed the newborn from head to toe. So you need to start from the face. You press on it. If it happens that the child is grown, that is why we'll be saying that the child is suffering from one of the malnutrition. But fresh baby is as a result of edema. And this edema can be as a result of cardiac problem or renal diseases. So you need to assess the feet. And we have a way of assessing the feet of the baby. More serious ones are the generalized edema. And this one you can see in every aspect of the baby from head to toe. And this occurs with what? Respiratory distress syndrome, congestive cardiac failure, and then severe hemolytic disease. That is the destruction of the red blood cells. When you have these conditions in the baby, then you see the generalized edema of the baby. These preterm babies also suffer anemia. Anemia is very common in the baby. There are two types or phases of anemia. You know, in utero, they have very high HB, just for them to embark on their various activities, their life processes, for them to grow. But when they are being given birth to, within the first few weeks, this HB, high HB, is no more necessary, because now the child is in the external environment and the child does everything on its own. But in utero, the baby depends on the mother through the placenta. But as the baby comes out, this high HB is no more needed. The high HB slowly falls over the first few weeks in the average preterm baby. The first one is the normochromo anemia, and is due to what? Reduced rates of the red blood cells production. You know, because they are not matured enough, the red blood cells too are not enough to mature. And this is very common in the preterm baby. Reduction in the rates of what? Red blood cells production. So what do we do for them? You need to fortify their feed with what? Iron or folic acid. And then we also have the microcytic anemia, occasionally seen in the second and then the third month of the baby's life. This one too, we also give the folic acid to the baby. Hemolytic anemia is also seen in the second month due to what? Vitamin E deficiency. They also have infection. So we need to fortify their food with these vitamins for them to prevent anemia. Now we come to the minor disorders of the preterm. These ones, they are mostly common in any preterm babies. For the males, the number one abnormality or disorder that you see in this preterm is the undescended testis. It's very common in males. And these are the reasons why the male preterm babies doesn't survive, because of the undescended testis. They also have multiple skin infection. These are some comes in the form of the strawberry marks, as in the last point, the multiple strawberry marks. Multiple skin infection, they will be having rashes, the pemphigus, the impetigo. All these skin rashes occurs in them. But with good management, they are able to survive. And then they also have umbilical hernia. With this one, you see examples. Some of them, because the umbilicus is not well formed, you see the intestinal content protruding through the umbilical cord. So they normally have this umbilical hernia. and then the multiple strawberry mark. You see some patches on the skin of the baby. We are done with the preterm baby, the characteristics, and then how to manage them. Now we are coming to look at the next categories of preterm babies, which is the low birth weight babies. So when we talk of low birth weight babies, what are we referring to? These babies can be born term or preterm. So low birth weight babies lies between 2.5 kg or less than 2.5, 1.5. So it's between 2.5 and then 1.5 kg. And they can be born term or preterm. What are the causes that brings about these low birth weight babies? We have the maternal diseases, placenta insufficiency, and then we are saying that these low birth weight babies fall below the what? The 10th percentile divorce score. And when you take the Road to Child Health record book, you see this 10th percentile, that we have the 90th percentile and then the 10th percentile. But with these low birth weight babies, you see them falling below the 10th percentile. When we get to the weighing card, you will see the percentile that I'm referring to. So when we have the above the 10th percentile, then the child within the normal, but below the child is low birth weight. Light for dates or small for dates babies. These are babies whose weight is below the 10th percentile. The baby can be preterm or posttermed. Causes, we are saying that is as a result of placenta insufficiency, which is often associated with what? Preeclampsia, when the mother develops high BP during pregnancy. So the placenta is not able to plant well. We can have the placenta previa or placenta abruptio. And I believe we've talked about this previa and then abruptio in your obs and gynae class. It can be also due to maternal chronic illness. And we've talked about this illness when we were looking at factors that influence growth and development. It can be what? Non-disease or disease illness as a result of sickle cell anemia or diabetes mellitus, or some of these infectious diseases, syphilis, gonorrhea, and then the rest. They can all bring about these light for days babies. You remember that when we were doing the factors that influence prenatal development, we came across these things. And I mentioned that if the mother is having these conditions, the baby can be born preterm or stillbirth. So if the baby doesn't come out early, then the baby may die in utero. We also have extreme maternal malnutrition. If the mother is not getting enough rich, nutritious food, the baby will not get good nutrients to mature. Therefore, the baby may tend to come out early or may die in utero. The mothers who smoke, heavy smoking mothers, during pregnancy and you are smoking, the likelihood that you will give birth to a premature baby is very high. And some of them even, they don't give birth at all. Some of them are barren because of heavy smoking. Excessive intake of alcohol also bring about this premature delivery. Congenital abnormalities. Some of them, the moment there's fertilization, there's some form of abnormalities. And some of them by nature, I always say that most of the abortions that occurs is as a result of these congenital abnormalities. God by his own way know that the fetus that is being formed will not be a normal human being. So the best way is for the baby to die or the baby to be born prematurely. And when they have these congenital abnormalities, the moment they are being born, within some few weeks, they pass away. Maternal drug use can also bring about this premature delivery, congenital infections, and then normal small babies from small mothers. Some mothers, because they are small, the uterus is also small. Therefore, the uterus cannot accommodate big babies. So, naturally, because the mother is small, the mother will give birth to a small baby. Let's look at the features. How would you identify light for date baby? What are some of the things that will tell you that this is light for date baby and not a preterm baby? So we are going to look at their features, their clinical features, so that the moment you see a light for date baby, you can easily tell that this is a light for date or small for date baby. The appearance of the baby. How does the baby look like? They have this wasting of soft tissues. So the moment you see the baby is very small, limp. I mean, you see the wasting features, like a child suffering from marasmus. They also lack subcutaneous fat. Skin are very loose and then rather dry, often peeling. So some of them, you see some in the post-dated babies. Their skin are very loose, dry, and then peeling. And then the color is also discolored. And then you see venous caseosa at some parts of the body. You can also easily see the rib bones protruding out. And then the abdomen is also very hollow, like somebody who, like 10 days, has not eaten. So you see all these features in light or small for date babies. Now the scalp. The hair too is very scattered on the head. The scalp bone feels relatively hard, not like the preterm when we are saying that the scalp is very soft. This one, you could see that everything is formed, just that the baby is small for the delivery. The head has often grown well compared to that of the body. Umbilical cord is thin and often has what? Yellowish brown color. And most of the time, those of them born between the weight of 1.8 are very what? Vigorous and active. And if matured, may look what? Hungry. So you need to feed them. Such baby, we are saying that they are not getting good nutrients. So the moment they come out, you need to feed them. Other than that, they will die of hypoglycemia. How do we manage these babies? Light for this. How do we manage them? Remember, I've told you they can be born preterm or they can be born post-term. So the moment you identify such a baby, the management starts from the labor ward. And then you need to resuscitate them. After you've managed them at the labor ward, you resuscitated them, quickly transfer them to NICU. And I believe you know what NICU is now, to control the temperature within the environment. Hypoglycemia is very common in the first 4 days. And then the major reason for identifying this group of infants is very important, because if you don't identify them, hypoglycemia will kill them. And when they have hypoglycemia, it's accompanied by what? Hypothermia. So these two, if you are not able to provide them with the warmth, you are not able to feed them on time, these two activities will kill them. Hypoglycemia and then hypothermia. They cannot maintain normal blood glucose. So also we need to give them the feed for the liver to start functioning. To prevent these problems, breastfeeding is started as soon as possible after birth. And then the baby is fed every 4 hours. And that is why when we send the baby to NICU, we allow the mothers to come every 3 hours to come and feed the baby. After feeding the baby, the mother needs to express some of the milk. And then every hour, you feed the baby with the breast milk. Then you need to monitor the blood sugar. Every 4 hours, you need to monitor the sugar of the baby for 48 hours so that you prevent this hypoglycemia in the baby. If the blood glucose is below 2.5 millimole, then you have to give a bolus. It's very dangerous, and the baby can go into hypoglycemia. So you need to give a bolus of 10% dextrose. If it's below 1.5, then you need to give 50% dextrose, 10 ml of 50% dextrose. Then they need to what? Use supplementary formula if necessary, especially when the breast milk is not producing. You need to fall on what? The formula, and then you feed the baby to boost the blood glucose of the baby. What are the common problems associated with these light for date babies? The number 1 is asphyxia. 2, meconium aspiration. The third one is hypoglycemia, polycythemia, and then fetal alcohol syndrome. Fetal alcohol syndrome comes about when the mother is alcoholic. And that is where the child, after birth, the child is showing signs and symptoms of what? Alcohol withdrawal. There is also twin-to-twin transfusion, especially when we have multiple pregnancy or when the light for dates is due to multiple pregnancy. Here you see, most of the time, you see one twin bigger than the other. It means one twin is taking all the nutrients from the mother. So most of the time, you see this twin, one twin bigger than the other. Prognosis. Most of them grow very well when they are being taken care of. Even the preterm babies, if you are able to take good care of them, they matured and grow very well. Some of them have mild mental retardation. Also, some of them also suffer from epilepsy. I'm saying that the earlier we identify them, the better. So if we are able to identify them very fast, manage them, we correct all these deformities. There's also minor neurological disorders like hyperactive behavior and specific learning difficulty. So most of the children that we say that they are hyperactive, they are having learning difficulty, this is how they started, right from birth. Something went wrong and then affects the mental development of the child. The very light for date babies, what about them? Who has suffered malnutrition or hypoxia in the 3rd trimester may grow what? Slowly. So you see some people, because the mother is not able to give birth at term, or even if it's at term and not at the appropriate weight, they have this retarded growth. And then you see the child remaining very small throughout the childhood. We are now going to look at large for date babies. We talk about preterm babies. We talk about term babies. light for date babies, we are saying that they can be born at 10 or post-10. We are going to look at large for date babies too, and then how they also comes about. We are saying that these babies who have the excess since what? Intrauterine growth. So half of them, they are big right from utero. These babies can be born preterm or term or post-term. So you could see with the preterm, they are born before the 37 weeks. Light for dates, they can be born term or post-term. The large for dates babies too, they can be born preterm, term or post-term. The main causes is the maternal diabetes mellitus, especially for these large for dates babies. It's as a result of what? Maternal blood sugar. Another cause for this preterm baby is the Wedeman's syndrome. And this we don't normally see in our country or in Africa. But the commonest one that brings about this large for dates babies is the maternal status of diabetes mellitus. The baby is usually large and heavier than the period of gestation. So if the baby is even born preterm, that is before the 37 weeks, so the baby will be weighing more than 2.5 kg. The umbilical cord is very thick. Bulging cheeks. Etunism is also present. And then they also have this Cushing syndrome. This heaviness of the baby is not as a result of edema as we see in preterm babies and then light for date babies. No. This heaviness is due to what? Real growth and not just fat or edema. It's real muscles. This occurs as a result of the excess sugar in the blood. What are the problems associated with this large for these babies? The commonest one is hypoglycemia. Because these babies are feeding on excess sugar in utero, when they come out, they need this sugar to continue to go on. But as the baby is now outside, baby is no more depending on the mother. Then the baby starts experiencing hypoglycemia. So quickly, you need to transfer this baby to NICU, and then they start feeding the baby with formula. Because at that stage, the mother cannot express the breast milk. They also have respiratory distress syndrome. Trauma may also occur during delivery, and that is the need where we need to give the mother episiotomy so that it will aid the delivery. Because if you allow this large baby to pass through the birth canal, the probability that the head will be damaged is high. So we need to avoid trauma. We have to give episiotomy to aid the delivery of the baby. They also have congenital malformation, polycythemia, that is excessive red blood cell breakdown, is also present in large for date babies. And then occasionally they have hypokalemia, that is excess, less calcium in the blood. And then the Eileen memory diseases. So these are the problems that large for date babies comes with. So the moment they are being born, we need to assess these babies and see that all these conditions that we are talking of are not present in the baby. So how best do we manage these large for date babies? One, because of the hypoglycemia, blood glucose falls very fast. So within 2 to 6 hours after birth, the baby has to be breastfed. We need to feed the baby with the breast milk. Other than that, the baby will go into hypoglycemia. So breast milk or formula need to be given. You have to start it before 2 hours after birth. They need to check the blood sugar every 2 hours within the first 12 hours. So when the baby is being born, every 2 hours, you check the blood sugar. Every 2 hours, you check the blood sugar for 12 hours. Then you can say that the blood sugar is now stable. And then you check the sugar every 4 hours. You also need to give glucagon, but we don't normally use the glucagon. First line of action is to give the bolus. We give 10% or 50% dextro bolus to raise the blood glucose. Then they also have hyperinsulinemia, and this will resolve in what? 48 hours. Because of the high insulin in the blood during utero, the moment they are being born, we still have this high insulin. So you need to what? Maintain the blood sugar level of the baby. If you are able to maintain the blood sugar level of the baby, this high insulin reduces within 48 hours. They also have this unusual hypoglycemia. So we need to what? Every 2 hours, you need to feed this baby. And all these things will cease after the first 2 days of life of the baby. That is 48 hours. This brings us to the end of today's lesson. Thank you very much.